So let's start with our first question. So our first question is, child came to the OPD and was prescribed a glass of -1 diopter cylinder at 180 degree in the right eye and same -2 diopter cylinder at 180 degree in the left eye. Okay. So what is the correct description of this type of refractive error? So they have asked about the type of astigmatism. So your options are compound hyperopic astigmatism with the rule astigmatism, compound myopic astigmatism with the rule, simple myopic astigmatism with the rule, or simple hyperopic astigmatism with the rule. So how to basically solve these type of questions? So first of all, I have made this line diagram. So what they have asked is -1 diopter cylinder at 180 degree. So whenever there is a degree that is given, what you would have to do is that you have to basically give the power perpendicular to the axis that is given. So the axis that is given is 180 degree. So power would be at 90 degree vertical axis. Okay. So this is -1 here and similarly -2 here because it is given at 180 degree. Do you all follow me? Give me a thumbs up. Okay. Now you have 0 here and -2 here. So what is happening here is that this is a simple myopic astigmatism. This is a simple myopic astigmatism. Okay. And this is, you have myopic power in the vertical meridian, which is more than horizontal meridian. This is my vertical meridian and this is my horizontal meridian. Is it clear? Okay. So you have more power in the vertical meridian as compared to the horizontal meridian. So this is basically with the rule astigmatism. You get my point? With the rule astigmatism. So you can remember it with the mnemonic VMMC. Okay, so we have a very famous medical college in Delhi, Vardhaman Mahavir Medical College. So VMMC, where vertical meridian is more curved. More curved means more myopic. Okay, so my vertical meridian is more curved. So that means the patient is having a with the rule astigmatism. Okay, so the answer here is simple myopic astigmatism and with the rule astigmatism. So that means astigmatism is a very important topic, have been asked twice in last 3 years. So please do a lot of questions of that. Okay, so this is the next question. So there was an instrument that was given here. Now in this instrument they have asked where it was used. So your options are measurement of squint, testing the binocularity, measuring of proptosis, and the fourth option is measurement of ptosis. So where it has been used. So what is this instrument? First of all, this instrument is basically a Hertel's exophthalmometer. Okay, so our diseases like thyroid ophthalmopathy or even in orbital cellulitis, we can have a lot of proptosis. So to measure proptosis, we need this one. This is basically called exophthalmometer. So it is used for the measurement of proptosis. So the answer here is C. So let us learn about few important points in a minute. So there are 3 types of exophthalmometer that is used in clinical practice. These are the Hertel's, Nagel's, and Luday's exophthalmometer. Okay, so these are the 3 types of exophthalmometer. Now, what is the normal range of Hertel's exophthalmometer? This was also a previous year question. So the normal range is around 21 millimeter. Okay, and if it is more than 21 millimeter, or if the difference between the two eyes that is more than 2 millimeter, that signifies the patient might be having a proptosis. Okay. Okay, let's move to the next question. So the next question is, a 11-year-old child presented with the decrease in vision, foul smelling discharge from the nose, proptosis with decreased vision. MRI head and orbit is shown as below. What is this type of orbital cellulitis? Try to answer in the comment section. So what is basically the answer here? The answer here is subperiosteal abscess with sinusitis. Okay. So can you all hear me? Okay. So what is basically happening here is that the patient is having a orbital cellulitis. What are the various important hints that are basically telling that the patient is having a orbital cellulitis? That the patient is having a decrease in vision, there is a foul smelling discharge, and there is proptosis. Okay, so these are the various signs that you can see which are basically pointing towards the diagnosis of orbital cellulitis. Okay, now what you can see here is there is a abscess in this area. Okay, so there is an abscess in the subperiosteal space. So the answer here is subperiosteal abscess with sinusitis. So what are the various important things that you have to know for the topic of orbital cellulitis? So first of all, see this video. Now what you can see here is that there is a what you can see here is there is a chemosis and congestion. Okay, so the patient might be having proptosis, chemosis and congestion, and you can see that there is a abscess in this area. So there are sinuses that are involved. So they ask lot of questions for the orbital cellulitis. Let us learn more about the orbital cellulitis. So first of all, what is the definition of orbital cellulitis? It is basically the inflammation of orbital septum and the contents which are behind the orbital septum. So if the inflammation is above the orbital septum, so septum is a plate which basically divides the lid into two parts. So if there is superficial infection, we call it preseptal cellulitis. If it is a deep infection, we call it a orbital cellulitis. So what are the various causes? It can be endogenous or exogenous. As I told you, the patient presents with proptosis, there is a limitation of movement, and in the later stages when there is a lot of compression, there can be a disc edema as well. Okay, and the most common that is the sinus that is involved, that is always the, as you are seeing it in the picture, ethmoidal sinuses. Okay, so these are few important points you should remember regarding the presentation of orbital cellulitis. Okay, so what are the various stages? The first thing is when the infection is above the septum, superficial to the septum, we call it preseptal cellulitis, followed by the orbital cellulitis. Then we have the subperiosteal abscess. Then we have the abscess in the orbital area, that is called orbital abscess. And last but not the least, we have cavernous sinus thrombosis. So now the infection has gone intracranially. So these are the various stages of orbital cellulitis, that is called Chandler's classification. Okay, let's move to our next question. So all are these questions which were previously asked. So these makes these topics also very important. If you have any doubt, you can put it in the comment section. We would discuss that also. So the next question is, a boxer with spectacle needs to go for a refractive surgery. So which of the following procedures he should not opt for? So very important is when you are basically seeing a question, please underline if there is a not or all of the above that is basically being asked, because that changes the answer to a different level. Okay, so here the boxer is going for a refractive surgery. So first of all, if I would have been clinician, I would have told the boxer that please avoid any refractive surgery. But sometimes what happens is, whenever you are getting the question, you have to basically answer the most correct one or most apt one that might not be 100% correct. So if you have got the question, you have to mark which one of them is best suited. So first of all, your options are LASIK, then you have PRKs, that is the photorefractive keratectomy, then you have SMILE, and the last one is radial keratotomy. So before I go to the answer of this question, what is important is to know what are these different types of surgeries. So first of all is, we discuss LASIK. So what happens in a LASIK is that you make a flap with the excimer laser or a femtosecond. You make a flap by a femtosecond laser or with the help of a metallic blade, and then you put excimer laser on the stromal bed and then you repose it again. This is called LASIK. What happens in a photorefractive keratectomy? That you basically remove the outer epithelium by scraping it or with the help of laser. That is called PRK. Now what happens in a SMILE? That is the small incision lenticular extraction, that you remove a part of stroma from a small 2 mm incision. Okay, so you are having a lot of things that you can do in the refractive surgeries. And the radial keratotomy, that was a type of surgery which was done previously. We used to make a lot of incisions in the cornea. Okay, so through these incisions, what we used to do is, we used to basically decrease the refractive power. So these are the different type of refractive errors that used to be refractive error corrections that is there in the practice. Okay, so both RK and LASIK should be avoided in these patients. But if you have got both the answers, both the options, I would go for the radial keratotomy as my answer. Because what happens is that whenever you are doing a LASIK surgery, sometimes what happens is that in 2 to 3 weeks there is a healing of the flap, and then the chances of flap displacement are less. But when you are having a lot of cuts, can you see there are a lot of cuts in the cornea, and then you have a something which is a fist injury to the eye, there are chances of perforation here. Okay, because there are chances of perforation, that might be catastrophic to the patient. So you always avoid a radial keratotomy in these patients. Okay, so I would basically not go for RK in this patient. So my answer here would be D. Is it clear, everyone? So though I would avoid any type of LASIK, but if this is given, I would basically not go for radial keratotomy because of the higher chances of perforation here. Okay, so now there was a question regarding NPCB-VI. So earlier there was a NPCB only. So that is the National Program for Control of Blindness, and now we have NPCB-VI. So it is VI. What is the meaning of VI here? The meaning of VI here is visual impairment. So what are our options here? So the first option is, it has better prognosis than the reach out strategy. So the second is, screening is done in periphery and the patients are transferred to the base hospital for the surgery. So option 3 is, screening is done in periphery and operated in the makeshift OT, and option D is, SICS is done in these patients. So which of the following they have asked is wrong? Okay, now the answer here is C. So option here is, screening is done in periphery and then operated in makeshift OT. Now, according to the new approach of the National Program for Control of Blindness and Visual Impairment, now the patients are transferred to the fixed facility like institutes or hospitals where there is more facility and there are less chances of any catastrophic infections like endophthalmitis, and if there is a complication they can manage that also. Okay, so now there are less incidences of endophthalmitis as it was used to be earlier. Okay, so it is not makeshift OT, but they are being transferred to the base hospital. This is the new strategy of the NPCB VI. Now, what are the various important things that you should know regarding the National Program for Control of Blindness and Visual Impairment? I would be telling you. So, please take a screenshot of this slide. So, first of all is that in the revised strategies, they have basically told that please shift from the eye camp approach to the fixed facility. This is called reach in approach. Okay, so this is called reach in approach. Now the second thing is that now they are not only having a focus on cataract, they are focusing on comprehensive care. Now they are focusing on refractive errors as well. The patients who are having a low vision, that means that the vision is less than 6 by 18. The patients who are small child and having a blindness, so the childhood blindness, corneal blindness, glaucoma, diabetic retinopathy. So now all of them are focused. It's not only cataract that is focused. The third thing they have basically told in the NPCB VI, the new approach, remember this was not being earlier asked, so this is an important question, that the services are to be provided not only in the cities, they have to be provided in the tribal and the rural area as well. This is the third important point. The fourth important point is it is not only the government that is providing the various services, it has to be the private sector as well. So there is a strong public private partnership that has to be given. The last but not the least you have to remember is that the mode of surgery they have recommended is a small incision cataract surgery. Okay, so remember the reach in program. So now we have a reach in program, so that focuses on fixed facility surgery. Okay, so now the patients have to be screened in the periphery and then they have to basically come to the main hospital, not in the makeshift hospitals. Is it clear, everyone? Okay, so the next question is a patient presented with non-proliferative diabetic retinopathy. Which of the following lesions are not seen in it? So what they have asked is they have asked about the difference between the various manifestations of the PDR, that is the proliferative diabetic retinopathy, and NPDR, that is the non-proliferative diabetic retinopathy. Okay, very important image based question. So your options here are hard exudates, intraretinal microvascular anomalies, dot blot hemorrhages, and the neovascularization of disc. Now let us see what is the difference between the fundus photograph of a patient with diabetic retinopathy. So first image you can see that there are some hemorrhages, some exudates here. This is a patient with a non-proliferative diabetic retinopathy. Okay, and the second image what you can see here is that you can see some new vessels which are growing in the retina and at the disc. So this is a proliferative diabetic retinopathy. So you can have a non-proliferative diabetic retinopathy, you can have a proliferative diabetic retinopathy. And whenever you are being asked what is the most important risk factor, remember another question, what is the most important risk factor for diabetic retinopathy? The most important risk factor is the duration of diabetes. Okay, so the duration of diabetes, though all the factors, the in control of diabetes, the hyperlipidemia, renal factors, all are important, but the most important one is the duration. Okay, so now we go to the what are the various manifestations of the diabetic retinopathy. So first of all, the first important and the earliest manifestation is the microaneurysm, that is the outpouching of the capillaries. Okay, so that is called microaneurysms. Now after the microaneurysms, you can have hemorrhages in the inner retinal layers of the patient, that is basically called dot blot hemorrhages. And if the hemorrhages are there in the superficial layer, we call it flame shaped hemorrhages. Then you can have hard exudates that are there in the inner layers, and you can have RNFL infarcts. Okay, so RNFL infarcts are called soft exudates, or they are also called the cotton wool spots. So these are the most important manifestations of the non-proliferative diabetic retinopathy. Please remember that before we move to the proliferative diabetic retinopathy, there is one more manifestation where there are abnormal communication channels between the veins and the arteries. These are called intraretinal microvascular anomalies, the IRMAs. Okay, and whenever they ask about the management of non-proliferative diabetic retinopathy, the management is basically you have to do conservative management. You do not have to put any anti-VEGF or do not have to do a pan-retinal photocoagulation. Just management is control of the systemic factors in a patient of non-proliferative diabetic retinopathy. Is it clear, everyone? Just give me a thumbs up. Okay, so after this, we move to the proliferative diabetic retinopathy. So whenever we talk about the proliferative diabetic retinopathy, we have two important things that come into our mind. The first one is that these patients have neovascularization. Proliferation, definitely the patient would have a neovascularization, new vessels, as you can see at the level of disc as well as at the level of retina. So you have neovascularization of disc as well as you have neovascularization elsewhere in the retina, and sometimes these vessels, they can bleed and then they can cause vitreous hemorrhage. So we can have neovascularization and vitreous hemorrhage, and they can ask about how do you manage these patients. So whenever you have a proliferative diabetic retinopathy, you have to basically photocoagulate all the retina. As you can see here, we have beautifully done a photocoagulation of the peripheral retina. So what is this? This is called pan-retinal photocoagulation. So my management here is PRP in the patients of proliferative diabetic retinopathy. But if the patients have macular edema and non-proliferative diabetic retinopathy, first I would give anti-VEGF injections like ranibizumab there before going for the further treatment modalities in this patient. Okay, now we go to some more image based questions, fundus based questions in ophthalmology. So sometimes they ask about the retinopathy of prematurity as well. So whenever we talk about ROP, the retinopathy of prematurity, so definitely they are there in the preterm or premature infants. And second very important point here is that these patients are exposed to higher concentration of oxygen. So these patients, the lungs have not developed and they are getting more oxygen as compared to what was required. So that basically causes the vasculopathies there. So this is the basic concept of ROP. So where you can get a demarcation line here, and this is the vascularized retina and this is the avascular retina. Okay, so you have a vascularized segment and you have a avascular segment. This is most important whenever you talk about the retinopathy of prematurity. Okay, so now they ask about the new babies to be screen guidelines. So if you are in a pediatrician, you are a pediatrician and you have basically done a delivery, there is a premature baby. So if what are the various factors that should be there in your mind when you have to basically refer the patient to ophthalmologist. So pediatrician has to refer the patient to the ophthalmologist. What are the various guidelines that you should remember? So first of all is that these patients are low birth weight babies. So any baby which is less than 2 kg of weight, or the gestational age is less than 34 weeks, or if the gestational age is between 34 to 36 week, but this is a high risk baby. So let's say the patient is on blood transfusion, he is on supplement oxygen therapy, or the patient got sepsis. So these are the various high risk conditions. If the patient is having that, or if the pediatrician is not very much sure about the clinical course. So any child, even if let's say the history of gestational age is not very much collaborating with the child, in that case he can refer the patient even if it is more than 36 weeks. So that is a pediatrician call. So infants with unstable clinical course can be sent for a ROP screening. But if there is a patient who is, let's say, 33 weeks and he is not sent for ROP, and if the child gets the ROP later on and there is a visual impairment, then the pediatrician is basically guilty there. Okay, so very important is for the clinical point as well. If you are there in the as a you are there as an intern or pediatrician, please, these guidelines are very important for you in your clinical practice as well. So then there is a question regarding the APROP, that is the aggressive posterior retinopathy of prematurity. So that has been asked as APROP. So what is APROP? That is basically if the ROP is located between the zone 1 and zone 2 and there is a aggressive tortuosity and dilation of blood vessels. The second thing is that very important is why these type of ROP is important, because they do not basically follow a definite course. From one stage to other stage, they can go very rapidly. So they might be at stage 2 and within a week they go to stage 4 or stage 5 rapidly. So these children have very high risk of blindness. So you have to photocoagulate these patients very early. Okay, so that is a very important point whenever you are talking about the APROP. Now, you might be having a question, what is the meaning of zones and what is the meaning of the stages? So, very shortly, the zones, you can remember that zone 1 is something which is the having the optic nerve and macula. So, that is the most severe zone. So, if the ROP comes here, that would be more severe. Zone 2 is a bit in the mid periphery and zone 3 is totally in the periphery. So the ROP that is there in the zone 1, that is having more chances of causing blindness, and the zone 3 is having less chances of causing blindness, so that is less severe. But when we go to the stage 1 to stage 5, stage 1 there is just a demarcation line, and stage 2 there is a ridge, in stage 3 there is a proliferation, stage 4 there is a partial TRD, partial tractional retinal detachment, and stage 5 there is a complete tractional retinal detachment. So as you go down from stage 1 to stage 5, the severity is increasing. Okay, so severity is increasing in the APROP in the stage 1 to stage 5, and they do not basically follow a definite trend. That is the most important point you have to remember. Okay, so the next important fundus based image they can give is regarding the hypertensive retinopathy. So like diabetic retinopathy, the hypertensive retinopathy, the basic pathogenesis is that what hypertension causes is it can cause constriction of the blood vessels. So there is a vasoconstriction, and when there is a vasoconstriction, that causes increased vascular permeability. So the two important points you have to remember regarding the pathogenesis is vasoconstriction and the increased vascular permeability. Now, these patients who are having a hypertensive retinopathy, like a diabetic retinopathy, they can have a lot of presentations. Okay, so let's move about that and learn a bit about that. So, the first thing they get is the generalized and focal narrowing of the blood vessels. As you can see here, there is a narrowing of the blood vessels. Okay, so it can be generalized or it can be focal, and what this causes is this causes the arteriolar nicking, which can basically lead to various signs that are called Salus sign, Bonnet sign, and Gunn sign. So Salus sign is basically the something where you can get a tapering of the blood vessels, and bonus sign there is the banking of the blood vessels, and then you can have copper wiring and silver wiring. As you can see, can you see here, this is the silver wiring of the blood vessel. Okay, and then like in a diabetic retinopathy and hypertensive retinopathy, you can have the various types of hemorrhages, the dot blot hemorrhages as well as superficial hemorrhages. Okay, and in the patients who are having a malignant hypertension, you can have disc edema. So if there is a patient who is having a 180 by 100 blood pressure or 200 by 120 blood pressure, and they ask what is the finding that you might get in the retina, so you can get all these findings plus you can get a disc edema. So if there is a chronic hypertension, you can get generalized focal arterial signs, but if there is a acute hypertension, you can have a disc edema there. So whenever there is a disc edema in malignant hypertension, that is a very important risk factor and the patient can die very quickly. So you have to decrease the blood pressure as soon as possible. Okay, so these are some important points you have to remember whenever you have a hypertensive retinopathy related question. Now we come to the next image based scenario where they ask about the retinal detachment. So there are three types of retinal detachment: rhegmatogenous retinal detachment, exudative retinal detachment, and the tractional retinal detachment. Let us learn a bit of more about that. So first of all is the rhegmatogenous retinal detachment. As you can see in the picture, so there is a separation of the neurosensory retina from the retinal pigment epithelium. And why this has happened? This has happened because there is a hole or tear in the retina, and from there the liquefied vitreous is going inside and causing the separation of the neurosensory retina. So this is the detached retina and this is the attached retina. Okay, so this is basically the rhegmatogenous retinal detachment. So rhegma here means there is a retinal hole or more commonly retinal tear. Okay, now the second important question that they ask about the rhegmatogenous retinal detachment is the various risk factors for the rhegmatogenous retinal detachment. So all the conditions which can cause the retinal hole or they can cause a break in the retina, they can cause a rhegmatogenous retinal detachment. So the lattice degeneration, the retinal tears, those patients who are having high myopia because there would be a thinned retina there, or due to trauma when there is a vitreous movement. So these all are the risk factors for the rhegmatogenous retinal detachment. Now we come to the various clinical features of the rhegmatogenous retinal detachment. So what the patient would say is that, sir, suddenly there are flashes in front of my eye and there are some black spots, floaters coming in front of my eye. So flashes are more important as a risk factor as compared to floaters. And when you do a retinoscopy of this patient, you can get a gray reflex. Now there is an important sign in the patients of rhegmatogenous retinal detachment that is called Schaeffer sign. So what is basically Schaeffer sign? When we see the patient on the slit lamp, in the anterior vitreous, you can see the cells or the pigments. This is basically called the Schaeffer sign. And if you are seeing a Schaeffer sign, that means the patient is having a rhegmatogenous retinal detachment. Okay, so the next important type of retinal detachment is the exudative retinal detachment. As the word suggests, there is a exudation. So that means that we have the choriocapillaries or the retinal capillaries that are basically causing the exudation, and that is causing the retinal detachment. So unlike the patients of rhegmatogenous retinal detachment, as there is no tear, so there would be no flashes or no floaters, but there is a fluid inside the retina. So when I would change my head position, the configuration of the retinal detachment would also be changing. So this is basically called shifting fluid. Okay, so there would be a convex configuration and there would be a shifting fluid. Now they ask, sometimes they would give you a picture like this where there is a retinal detachment. Can you see the exudates here? Okay, and they would ask what are the various causes. So sometimes they would give a picture like the patient, there is a patient who is having a pregnancy, and then the patient is having this picture. So what is the cause? So there might be a increase in blood pressure there. So there might be a toxemia of pregnancy. Okay. Now, the second is that this can happen in various systemic disorders, and the most important systemic disorder you have to remember is the VKH syndrome. Even sometimes in intraocular diseases, like there is a inflammation of sclera, that can also cause the exudation. So, like the patients who are having a posterior scleritis, they can also basically get this, and there might be exudation or serous fluid at the level of macula in a young adult. That is basically called a central serous retinopathy. So another important cause is the central serous retinopathy, and then intraocular tumors like malignant melanoma and retinoblastoma, they can also cause the exudative retinal detachment. Okay, let's move to the next type of retinal detachment, that is the tractional retinal detachment. As the word suggests, there are tractional forces, as you can see, fiber optic strands that are basically causing the pulling of the retina from its bed. This is called tractional retinal detachment. And whenever you are having a tractional retinal detachment, the most important thing to remember here is that there would be no shifting fluid, no flashes, no floaters, unlike in the patients of the rhegmatogenous retinal detachment and exudative retinal detachment. So what you would be getting is that you would be getting decrease in the vision according to the what are the various places where there is a retinal detachment. So what are the important causes? The most important causes, or the most common cause in Indian population, is the proliferative diabetic retinopathy. And if they are asking about the child, I told you the fibrotic strands in the child, that is the ROP. Okay, sometimes even in the patients who are having vasculitis like Coats disease or sarcoidosis, or even in the patients who are having inflammation because of some parasite like Toxocara, they can also get a tractional retinal detachment. So these are some important points regarding the retinal detachment. So from the retinal detachment, we move to our next important type of fundus picture. They can give something like this, which is basically a tomato splash appearance. That is, you are having superficial flame shaped hemorrhages all around the fundus. This is basically a patient having a central retinal venous occlusion. Okay, so you are having a central retinal venous occlusion. And why this is happening? This is happening because of the thrombus that is there in the central retinal vein. So you have a central retinal vein and there is a thrombus blocking there, and that causes the back pressure and causes hemorrhages all around the retina. So you would be having a lot of hemorrhages all around the retina. A tomato that is splashed, this is called a central retinal venous occlusion. Now very important is, sometimes if you have ischemia as well, there is a blockage of the arterial supply as well, you would get a disc edema. As you can see here, there is a disc edema also here. So that is a sign that this patient might go into a neovascular glaucoma. Remember, the patients who are having a central retinal venous occlusion, you have to measure the IOP repeatedly, because around 3 to 4 months there might be neovascularization of iris that can basically cause a central retinal venous occlusion, that can basically cause a neovascular glaucoma in these patients. So they have asked a question in the INI-CET exam as well as in your NEET PG exam regarding the 90-day glaucoma, that is the neovascular glaucoma. Okay, now if they ask that there is a patient, there is a young patient, a 26-year-old guy, and this 26-year-old guy is having a tomato splash appearance, what is the most important investigation that you would do? So in this patient, we would definitely go for the lipid profile. We would see the blood pressure, diabetes, but very important here is I have to rule out the various important causes of hyperviscosity of blood. So the causes like the patient is having a polycythemia, multiple myeloma, okay, hyperhomocystinemia. Very important is hyperhomocystinemia. They have to be basically ruled out because they can also cause the central retinal venous occlusion. So like central retinal venous occlusion, we have a central retinal artery occlusion as well. But in total contrast to the central retinal venous occlusion, in central retinal artery occlusion, we would be having a pale retina. Okay, so we would be having a pale retina here, and that is very important because in these patients you can have a cattle trucking of veins. Okay, so you can have a cattle trucking of veins like this. Okay, this is called cattle trucking appearance of retinal veins. So these are very important points regarding the central retinal artery occlusion. Now, if you can see this image that there is a retinal edema, but in the center you can see a bright spot here. So what is this bright spot? This bright spot is basically the cherry red spot. Okay, so whenever you are having a cherry red spot, so you have to remember regarding what are the various differential diagnosis of cherry red spot. Okay, so the causes here that you have to remember is, as I have shown you here, the patients who are having a central retinal artery occlusion, the patients who are having a Tay-Sachs disease, the patients who are having Niemann-Pick disease, the patients who are having gangliosidosis. So it is not all everything, it is the type 1 GM1 gangliosidosis and GM2 gangliosidosis. Okay, so type 1 GM1 and GM2 gangliosidosis, these are the two types of gangliosidosis where you have a cherry red spot. Okay, then the patients who are having a methanol poisoning. So we had made a reel also like this, that if there is a patient, there are a person who is taking alcohol and there is a contamination by methanol, that patient can have a blindness there. Okay, so if why there is a blindness? Because of the methanol poisoning. So there is a something where you give ethanol to the patient, okay, as an antidote. So the methanol poisoning and the patients who are having trauma. Okay, so if the patient is having a retinal edema because of the trauma, that would basically also show you a patient a cherry red spot. Okay, so trauma Berlin's edema is a cause of central retinal artery occlusion. Okay, so after this we move to our next image, that is the image where you can see pigmentation around the retina. So there is a bony spicule pigmentation, there are attenuated arteries, and there is a optic atrophy. So all these triad, if you basically see all these images, this basically shows the patient is having a retinitis pigmentosa, which is the most common retinal dystrophy. Remember, the retinitis pigmentosa can affect both type of your photoreceptors. First, it basically affects your rods, and then your cones would be affected, and the gene involved would be the rhodopsin gene. So two most important points you get confused for the retinitis pigmentosa is, first of all, the most common inheritance pattern. So the most common inheritance pattern is the autosomal dominant, and sometimes they ask what is the first symptom of the patient. The first symptom of the patient here is night blindness. Okay, what are the investigations that you would do? Though it is a clinical diagnosis, but the investigation that can help you for the prognosis is the ERG. So in the ERG, the electroretinogram, you would have reduced A and B waves, and you would get ring scotoma whenever you do a perimetry. Okay, so these are some important points you have to remember regarding the retinitis pigmentosa. Okay, now the next image is the partial retinopathy. So partial retinopathy is something where you get sudden onset of the multiple hemorrhages all around the fundus. So like in the patient of central retinal venous occlusion, here you can also have the hemorrhages all around, but usually these hemorrhages are at different stages. Some are more bright, some are more yellowish. So this is basically a partial retinopathy. And remember the various causes of partial retinopathy with the mnemonic CHEAP, that is the patients having a chest trauma, head trauma, embolism, or acute pancreatitis. These patients are having hemorrhages all around the fundus with the loss of vision. So think about the partial retinopathy in these cases. Okay, with this we move to the various macular pathologies and the OCT pictures of the various macular pathologies. So see here the various macular pathology. The first one you can see The first one you can see here, there is cystic spaces in the inner retinal layers. So this is a patient having a cystoid macular edema. Here you are getting a exudation between the neurosensory retina and the retinal pigment epithelium. So this patient is having a central serous retinopathy. Here you can see there is loss of layers in the center of macula. So this is basically a macular hole. And in this picture you can see there is undulating pattern of the RPE. This is my retinal pigment epithelium. So there is some deposition beneath the retinal pigment epithelium. So this patient is having a dry ARMD. So various OCT based images they can also give you, and according to the OCT based images they can basically ask you various conditions. So please take a screenshot of this slide and remember this in your upcoming exam. Okay, so let's move to our next question, that is, what is the correct description of the stain and the filter that is used in this image? So what you can see here is that there is a bluish hue and you can see some fluorescent based images here, okay, fluorescent based stains here. So this is basically a cobalt blue filter which is being used, and with the cobalt blue filter there is a fluorescein dye. Okay, so this is a cobalt blue filter with the fluorescein dye which is being used here. Okay, so similar question was asked where they have asked about the diagnosis. So here you are seeing that there is definitely we are doing it with the cobalt blue filter, but you are not getting any fluorescent dye image based stain in the cornea. Okay, so that means there is no epithelial defect. So let's see various options. Corneal ulcer, whenever you are seeing a corneal ulcer you would definitely get epithelial defect. In the interstitial keratitis you would not get any epithelial defect. In granular dystrophy also you would have some popcorn like opacities in the center, and in band shaped keratopathy you would also have opacity like this in the center. So definitely this patient is having a interstitial keratitis. Okay, so the answer here would be B, that is the interstitial keratitis. Okay, so next, this was something which is was a more of a controversial question. So the question is, which of the following is the sequence of staining of the cornea for the patient of a dry eye? So the patient has come with a dry eye, and now we are going towards the for the diagnosis of this patient. Okay, so the three stains they have given here is that first the patient is having a sodium fluorescein stain, then we have the lissamine green and the rose bengal. Okay, so these are the various stains that we have used, and what is the sequence? So your options is 1 2 3, 1 3 2, 2 3 1 and 3 2 1. So I would go for A as the answer. Okay, so the staining pattern should be, first of all you have to do a sodium fluorescein. So you see if there to basically if there is any epithelial defect, and before that you have to basically see a tear breakup time. That is the most important and the first test you do in the patient who is having a dry eye. Okay, so first thing that I have to do is sodium fluorescein I would use, and after that the second thing I would do is I would basically do a lissamine green. So what the lissamine green does is, lissamine green can tell you about the conjunctival xerosis. Let's say the patient is having a vitamin A deficiency, so that would be seen more clearly with the help of lissamine green. And my third option would be, then I would go with the rose bengal. Okay, because rose bengal is more irritant to the cornea, so I would basically do it last. So this is my order of using the various stains when I basically do a dry eye evaluation test. Okay. Okay. So what are the various tear film tests that we do in the clinical practice? So first of all, what I told you is the tear breakup time. Okay, so the tear breakup time, I use a sodium fluorescein strip and then I open the eye and see it over the slit lamp and see when is the first dry spot that is coming, and that is basically called the tear breakup time. Then what I do is I do a Shermer's test. As you can see here, this is a Shermer strip I have put in the between the lateral two-third and the medial two-third and the lateral one-third of your eyelid. I have put a strip there, and then I know how much is the wetting of this strip. This is basically called the Shermer test. The third test I basically do here is I can do a Rose Bengal test and the Lissamine green test, which I showed you earlier. And the last but not the least, in the children and those patients who are not cooperative enough for the Shermer test, I can put a small thread here, as you can see, a small thread here, and see how the color changes of this thread. This is basically called, my friends, a phenol red thread test. That was also a previous year question. So these are the various dry eye tests. In short, you have to remember. Now we move to our next question. A patient presented with the intraocular pressure of 25 millimeter of mercury and the glaucoma is suspected. Which of the first is the specific parametric change you would suspect in this patient? Try to answer. So the patient is having a 25 millimeter pressure and you have to tell you about the first change in the visual fields that you would get in this patient. So I would definitely mark here as my paracentral scotoma. Remember, here also the word basically marks you what should be the answer. So whether it is a specific, your answer would be paracentral scotoma. But if they have not basically asked specific, they have just asked for the first parametric change, then your answer would have been isopter contraction. So with this, I basically tell you what are the various visual field defects in glaucoma. If they ask about the first one, that is your field of vision decreases, that is called isopter contraction. The field of vision decreases to a level when your blind spot is not seen whenever you are doing it, then this is called a bearing of blind spot, or when you see a enlargement of blind spot, this is basically the second visual field defect. But remember, whenever you are having a isopter contraction or there is an enlargement of blind spot, it can be also because of some other conditions, which was also a question that I would be just telling you in the next slide. The first specific defect that you see in these patients is a paracentral scotoma, and that can basically lead to a sickle shape later on, that is called a sedal scotoma, that would go to the horizontal midline and basically cause a arcuate scotoma. That would basically have a second one which is going in the inferior part as well, that is called double arcuate scotoma. And last is that there would be only tunnel vision, and even after that there would be a complete blindness. So that is the various important field effects in the chronological order for glaucoma. Now the next question they have asked is regarding the causes of enlargement of the blind spot. This was, remember, a AIMS 2021 question. So enlargement of blind spot, as I told you, can be seen in early glaucoma, but it can be also seen in the patients who have a choroid inflammation like choroidopathies, and it can be also seen in the optic nerve disorders like papilledema or optic neuritis. And even if there are deposits in the optic nerve head that are called optic nerve head drusen's, as well as in the patients with medulated nerve fibers. Remember, the myelin sheath is basically not there in the nerve fibers of the retina, but if there are small medulated nerve fibers, myelin sheath present there, that is called medulated nerve fibers. And if there is a tumor posteriorly, okay, there is a retrobulbar mass, that can also basically cause the enlargement of blind spot. So these are the various differential diagnosis of enlargement of blind spot. It can be seen in glaucoma, but it can be seen in the other disorders as well. So the next question was regarding, they have asked, this was the, I think, the toughest question that have been asked in last 3 to 4 years. They have given a ciliary body anatomy and have asked specifically regarding this space. This space, that is the space 7. Okay, and they have asked what is this space 7 called? Now, before I tell you about what is this space 7, I would tell you the various important points here. So first of all, you are seeing this point 3. So this is the lens and this is the equator of the lens. Okay. Now the second thing what you can see here is that in this area here we have the various ciliary processes. Can you see the finger like extensions? These are the ciliary processes. Okay. Then this is 2. Okay. So what is this 2? This is the vitreous and this is the anterior part of the vitreous, that is called anterior hyaloid phase. Then you have zonules here. Okay. Number 4. Can you see these zonules? These are the pre-equatorial zonules. Okay. 4. And similarly, this is my equator. This is pre-equatorial, and number 5 goes with the post-equatorial. Okay. So we have pre-equatorial zonules, then we have post-equatorial zonules, and there are few zonules which are basically joining the ciliary processes and the hyaloid phase. These are the called hyaloid zonules. Okay. And then we have space between the pre and the post-equatorial zonules. This is the space 1, that is basically called canal of Honavar, and we have space between the 5, between this 7, sorry, the 5 and the 6. So 5 is our post-equatorial zonules and 6 is our hyaloid zonules. So the space 7 is basically called canal of Petit. Okay. So here I am just showing you the question again. So they have asked about the space 7. So what is this space 7? This space is basically called canal of Petit. If any one of you want this diagram, you can just message to me. Okay. Or you can take a screenshot of this one. We would be putting it in our app also. This is how the various spaces of the ciliary body would be. And just remember, 2 spaces here. The one is the canal of Petit and one is the canal of Honavar. Canal of Petit is between the hyaloid zonules and the post-equatorial zonules, and the canal of Honavar is between the pre-equatorial zonules as well as between the post-equatorial zonules. So these are the various spaces in the ciliary body. Okay. So the next question is, they have asked about what is this type of direct gonioscope. Okay. So there are 2 types of gonioscope. One is your direct gonioscope and other is your indirect gonioscope. Okay. So this gonioscope is a direct gonioscope which is called a Swan-Jacob gonioscope. Okay. And the other type of gonioscope which you are seeing here, I am doing, this is the indirect gonioscope. Okay. So what is the difference between the direct and the indirect gonioscope? That is sometimes asked in your exam. So first of all is, this is my direct gonioscope, a Swan-Jacob type of gonioscope. Here you put it directly over the eye and see it in the gonioscope. You see the various angles. What we do with the gonioscopy, we basically see the various angles. So whenever you are basically having a direct gonioscopy, you basically see how is the angle structure. So in the patients of congenital glaucoma, where you have to do some surgeries in the angle, or the microinvasive glaucoma surgeries like goniotomy, or if you are going for the stent procedure, you have to have a direct visualization of the various angle structures. You use these direct gonioscopes. Okay. And your options are that you can use a Swan-Jacob, as you can see here. There are some other types of gonioscopes as well, like Richardson gonioscope and the Barkan gonioscope. So these are the various types of gonioscopes that are the direct gonioscopes. The more common one that we use in our patients in the OPD, that is indirect gonioscope, which we do it with the help of a slit lamp. So I put a gonioscope over the cornea, and then there is a reflection from the various mirrors of the gonioscope, and then I see it in the eyepiece of my slit lamp. So whatever I see is inverted. So if I am seeing a superior angle in my eyepiece, actually that is the inferior angle. So there is a indirect gonioscope. Okay, so light is going like this and then gets reflected. So superior means inferior and inferior means superior. So that's why it is called a indirect gonioscope, because the angle is seen after the reflection from the mirror. And these are of two types: either you can do a manipulation or a indentation. Do not go into details what is the manipulation and indentation, but remember the lens are the Goldman lens and these are the Pochner-Sussman lens. So the lens which I am using here is the Pochner-Sussman lens, which I am doing a indirect gonioscopy here. So the next question was, after putting phenylephrine eye drops 5%, there is a redness of eye which decreases and there is a blanching. So the patient comes with a congestion, but after putting a phenylephrine eye drops, the congestion has reduced. So what is your probable diagnosis? Your options are cataract, episcleritis, uveitis and scleritis. So first of all, cataract would not basically cause a redness, so that directly you can basically rule out that. Now you have episcleritis, uveitis and scleritis. Now remember, uveitis, the inflammation is interior, okay? And if you are putting a phenylephrine eye drop, it would not basically help. Similarly, the scleritis, there is a deep inflammation that would also basically not get resolved with the help of the phenylephrine. If there is a resolving of the redness, as you can see in this picture, that is because of the inflammation that is due to episclera inflammation, that is episcleritis. Okay, so episcleritis inflammation, you put a phenylephrine eye drop and the eye goes clear. So that is basically your diagnosis. Now let us learn more about the various types of uveitis, because that is a question that can be asked in the exam. So you can have a anterior uveitis where your iris and the anterior part of the ciliary body is involved, and then you have a pars plana involvement, that is called intermediate uveitis, and if you have a choroidal involvement, that is called your posterior uveitis. Now let us learn about few important points regarding the anterior uveitis. So first of all, there is a pathognomic feature of anterior uveitis, that means there is a cells in anterior chamber. If you are getting cells in the anterior chamber, that means this patient is having a active uveitis. The second question they ask is, there is a irregular pupil that is seen in the patients of anterior uveitis. What is the name of this pupil? This is basically festooned pupil. Okay, you get festooned pupil due to irregular posterior synechias. The third important thing is they ask about the drug of choice in the patients of anterior uveitis. So whenever you have uveitis, you would always have a drug of choice, that is steroids. Okay, so the topical steroids are the drug of choice in the patients of anterior uveitis. And if they ask what is the drug that would use to decrease the pain of uveitis or to decrease the formation of posterior synechias, your answer would be atropine, because that is the cycloplegic that we use. The next question they ask is, if you are getting a patient with granulomatous uveitis, what are the type of keratic precipitates that you would see here? As you can see in this picture, there are large mutton fat keratic precipitates. So large mutton fat keratic precipitates are seen in the granulomatous uveitis. And what is the most common cause of decrease in vision in these patients? The answer would be posterior subcapsular cataract. If they ask about the posterior segment anomaly in these patients, the most common posterior segment anomaly here is cystoid macular edema. And sometimes they ask about a triangle that is formed by the KP. What is the name of that triangle? Can anyone tell in our comment section? So the triangle that would be formed would be the Arles triangle. Okay, so these are some important points that you should remember regarding the anterior uveitis, and one-liners regarding the anterior uveitis. The second one is the inflammation of pars plana, that is called intermediate uveitis. And whenever you think about the intermediate uveitis, always know that this basically means inflammation of the pars plana. They so many times ask you about the pathognomic features of the intermediate uveitis. Remember, there are opacities around the inferior quadrant of the retina and near the pars plana, that is called snowball opacities and snow banking. So the snowball opacities and snow banking, they are the most important pathognomic features about the intermediate uveitis. So they would ask a question: a patient comes with the floaters and having the snowball opacities, what would be your diagnosis here? So my diagnosis is very clear, would be the intermediate uveitis. Remember, like the patient, or unlike the patient of anterior uveitis who would basically come with lot of photophobia, the patients of intermediate uveitis, they only complain of floaters. There are no keratic precipitates or cells in the anterior chamber, and the most common cause of decrease in vision in these patients is cystoid macular edema. And the management is there, we basically used topical steroids, but here we have to basically give the steroids near the ciliary body. So I would give it in the around here, just beneath my conjunctiva, that is called posterior subtenon injection, or I would give intravitreal steroids or systemic steroids to these patients. So these are some important points regarding the intermediate uveitis. And then we move to our next topic that is being commonly asked, that is staphyloma. So what is staphyloma? Staphyloma is basically protrusion of the uveal tissue. As you can see in this picture, there is a uveal tissue protrusion through thinned out sclera. So there is a, let's say there is a patient who has a thin sclera because of the enlargement of the eyeball, or there is a perforation of the corneal ulcer which has caused the iris to come anteriorly. So a sloughing corneal ulcer would basically cause anterior staphyloma. Something where there is a thinning around the limbus would cause intercalary staphyloma, like in the patients who is having a peripheral ulcerative keratitis, or the patients who are having a Murray's ulcer. And in the patients who are having a absolute glaucoma or trauma, you can have a ciliary staphyloma. In the patients who are having high myopia, you can have a protrusion around the equatorial veins, so that is called equatorial staphyloma. And you can have a posterior staphyloma in the patients of high myopia. So these are some various important types of staphyloma which can be asked in your exam. With this, we move to our next question, where they have asked which of the following triad is seen in the angle closure glaucoma. So if any one of you want to answer in the comment section, please do. So the triad that we see in angle closure glaucoma is the Vogt's triad. So we can have Vogt's triad, we can have Vogt's triad. So lot of eponyms in ophthalmology. So basically, when we talk about the Vogt's triad, we know we should remember a mnemonic, that is GSI. This is a very, this is a society in India, that is Glaucoma Society of India. So in this way, you can remember the various important components of the Vogt's triad. So first is you get anterior capsular opacities, that is called glaucoma flecken. Okay. The second is you get sphincter atrophy. Your pupil, around the pupil, you have a sphincter muscle, you have a sphincter atrophy, and you get the iris atrophy. So these are the three components of the Vogt's triad that you see in the patients of angle closure glaucoma. Okay, so then we are being asked about the primary function of superior oblique. So we have six extraocular muscles, and they are asking about the function of superior oblique. So before I tell you about the function of superior oblique, just remember a diagram like this. So in this way, you would never forget. So it has helped me in last 18 years to remember and conceptualize my idea of squint and my concept of squint. So this is my superior rectus, medial rectus, inferior rectus, superior oblique, lateral rectus, and inferior oblique. And these are my actions. This is my nose. Okay. So this is my superior oblique. So what my superior oblique is doing is, it is basically turning the eye towards the nose. Okay. So this is the action we call as intorsion. Okay. The second action is, what it is causing is, it is basically causing the eye to go down. So this is the depression, and third is it's basically moving the eye out. So this is the abduction. So remember, our superior oblique and inferior oblique, they are the primary rotators of the eyeball. So superior oblique is intortor and inferior oblique, that is extortor. And superior oblique basically causes the eyeball to go down, and inferior oblique basically causes the eyeball to go up. So these are the functions of the various extraocular muscles. Okay, so the next question was regarding which of the following is familial in your presentation. So your options were primary open angle glaucoma, myopia, retinitis pigmentosa, and retinoblastoma. So remember, all of them, primary open angle glaucoma, myopia, RP, and retinoblastoma, all are familial, all can have genetic predisposition, genetic components. So all of them are the answer. So primary open angle glaucoma, it can be both autosomal dominant as well as autosomal recessive. Myopia is usually seen as autosomal dominant. Retinitis pigmentosa can have more common as the autosomal dominant, but if it is associated with syndromes, it can be autosomal recessive. And the most severe but the least common is the X-linked recessive. And retinoblastoma, it can be both autosomal dominant as well as also autosomal recessive. More commonly seen is as autosomal dominant. Okay, let's move to the next question. Okay, so which of the following does not have a punched out appearance in the retina? Okay, so your options are retinal coloboma, congenital toxoplasma, rubella infection, and posterior staphyloma. So first of all, see the various important fundus pictures. So this is where there is a punched out appearance of the retina. So your retina is basically not developed here. This is basically coloboma. And in toxoplasma also there is a excavation around the macula or the perimacular region. This is toxoplasma. So toxoplasma also have a punched out appearance of the retina. Then we have posterior staphyloma. As I told you, posterior staphyloma is seen in high myopia. This is the fundus picture. As you can see, there's something which is a punched out, and when we do a USG in this picture, you can easily see there is a punched out appearance. So this is basically a patient with posterior staphyloma. So all of these options are definitely having the punched out appearance of the retina. One more thing that I would basically tell you is that punched out appearance can also be seen around the optic nerve head in the patients with optic disc pit. And very important here is, if you are seeing an optic disc pit, this can be an important differential diagnosis of a patient with glaucoma as well. So here also there can be an excavation. Now, if the patient is having a condition like this where you can see pigmentation around the fundus, this is basically called salt and pepper retinopathy. As you can see, this I have told you when I was talking about retinitis pigmentosa. So this condition can be seen in retinitis pigmentosa. It can also be seen in the drug toxicity by thyroidazine and also in the congenital rubella syndrome. Okay, so these are the various differential diagnoses of the patient with salt and pepper retinopathy, and this was also a previous year question. Okay, so next we move to our next question. Probable causative agent in a patient experiencing lag of ophthalmos, ocular paresis, and corneal anesthesia. So your options are Mycobacterium leprae, Onchocerca, Toxoplasma, and Mycobacterium tuberculosis. If any one of you want to answer it in the comment section, please do. Okay, so the patient is having a corneal anesthesia. So that means your cranial nerves is involved. Okay, and the patient is having a lag of ophthalmos here also. So these are basically the manifestations of Mycobacterium leprae. Very important is that leprae usually does not cause a posterior segment involvement, and in the cornea it can basically cause corneal anesthesia. It can cause nodes around the your conjunctiva. So that are the most important things you need to remember. And the other manifestations are that it can cause a bit of uveitis, can cause iris pulse. So that is an important differential diagnosis. If you are getting white spot around the pupillary margins, then basically suspect about the leprosy. This can also cause scleritis, and in the eye it can basically involve your eyelid and causes the loss of your eyelashes as well as bending of your eyelashes. That is called loss of eyelashes is called madarosis, and the bending of eyelashes is called trichiasis. Okay, then it can basically cause the there is a difficulty in basically opening of your eyelid. So that is basically you can have a closing of eyelid as difficulty as well as opening of eyelid difficulty. You can have a patient with lag of ophthalmos, and there is a invert turning of eyelid margin, that is called entropion. So these are some various important points that you should remember regarding the patient with a leprosy infection. Okay, so the next question is, a patient, a 28-year-old male female, came to the OPD with sudden loss of vision and RAPD. Okay, so there is a patient with sudden loss of vision and RAPD. Which of the following tests are needed to be done for the diagnosis? Okay, so your options are anti-NMO and MOG antibody, MRI head and orbit, blood sugar, LFT, RFT, and thyroid function test. So, what are the important things that you would do basically in this patient? So, definitely very good, Saurav. We would basically do a anti-NMO antibody, MRI head and orbit, and blood sugar, LFT, and RFT here. So, what is the diagnosis here? Can you tell me? So, what would be the diagnosis here? So, diagnosis here would be your optic neuritis. Okay, so you can have a patient with a disc edema here, and that would basically cause a symptoms like this, where you would have a loss of vision and RAPD. And the most common systemic disease which causes the optic neuritis is your multiple sclerosis. So that's why you need to basically go for a MRI head and orbit, as well as you want to go for a antibody NMO and myelin oligodendrocyte glycoprotein in this patient. Okay, now what is the treatment that you would give in this patient? Treatment is not the oral steroids, treatment is your intravenous steroids. And because you are going to go for intravenous steroids in this patient, that's why you need a fasting and PP blood sugar, serum electrolytes, blood pressure monitoring, as well as RFT in this patient. So these are some various important points you should look for when you are basically doing a treatment for a patient of optic neuritis. Now let's move to our very important question, that is regarding the interpretation of Snellen's chart. Now, there is a 36-year-old male who can read up to 6 by 6 in the Snellen's chart. What would be the angle that is made by the each letter of 6 by 6 line on the Snellen's chart at 6 meter? Now, what this question actually means. So, here you have a Snellen's chart, and the patient is having a 6 by 6 vision. Okay, he is at 6 meter distance. So this letter, what would be the angle that is made by this letter? This is what is the question, if anyone of you want to attempt. So what would be the angle that is made by the smallest letter of the Snellen's chart at 6 meter of distance in a normal human being having a 6-6 vision? So the answer here would be A, that is 5 minute of arc. So before I explain you the answer, let's go to the concept of Snellen's chart. So these letters which we see in the Snellen's chart, these are called optotypes. This is something we say, this is 6 by 60, 6 by 36, 6 by 24, 6 by 18, 6 by 12, 6 by 9, 6 by 6. Okay, so it's going down. So as we go down, the size of the optotype, that is basically decreasing. Is it clear? Okay, now what is the meaning of 6 by 6? Okay, so if the patient is having a 6 by 6 vision, that means that my patient can read the smallest letter at 6 meter, and a normal person can also read it at 6 meter. Okay, so my patient is having a good visual acuity like a normal human being. Now what is the meaning of 6 by 12? So 6 by 12 means the letter is big enough. As you can see here, this is my letter 6 by 12. Okay, so a patient can read it from 6 meter distance. Okay, but a normal person, because this letter is a bigger letter, a normal person can see it even at 12 meter. Are you getting my point? So this is a bigger letter. Because there is a decrease in the visual acuity, patient needs to come closer, but a normal person can see even at 12 meter. Okay, this is the basic fundamental of 6 by 6 vision, 6 by 9 vision, 6 by 12. So similarly, if we would have a 6 by 60 vision, so my patient can see it at 6 meter, but a normal person can even see at 60 meter. Okay, it is such a big letter that it can go, and a patient can basically, the normal person can see it even at 60 meter. So this is a big letter. Our patient's vision is low vision in this case. Okay, now the question they have asked is, what is the angle that is subtended here? So this angle that is subtended here, this is basically the 5-minute of arc. Okay, so the smallest letter, if this is the E, this smallest letter basically, if it is 6 by 6, this is subtending an angle of 5-minute of arc at 6 meter. Now if the question would have been that what is the angle subtended by the 6 by 60 letter, so 6 by 60 letter is a bigger letter. This was also a question. So the bigger letter, this one E, if they ask what is the angle subtended at 6 meter, this angle would be 5 into 10 times. Okay, remember this is 60 meter na, 10 times the 6. So the angle would be also 5 into 10 times, that is the 50 minutes of arc. Okay, so this is how you can basically do the questions that are related to the Snellen's chart. And one more question that I've asked before is, what is the minimum angle of resolution? Now what is the meaning of minimum angle of resolution? Minimum angle of resolution means that the two lines are separated so closely that our eye is able to distinguish them differently. Okay, so they are so close that if they are closer than that, I would think that this is only one line. So that is the minimum distance between the two lines, so that my eye can basically understand that these are different lines, not the same line, and this angle is 1 minute of arc. Okay, this was also a previous year question, so please remember it. Okay, so the next question was regarding they have basically asked few columns, they have written few symptoms and few tests, and in the other column you have to match. So your options are color vision, peripheral field of vision, Goldman applanation tonometry, and hypopyon in the column A, and in the column B they have fungal corneal ulcer, IOP measurement, Ishara chart, and perimetry. Okay, so color vision. So color vision, how you basically see, the color vision. Color vision you see with the help of which one? Ishara chart. The red green color blindness you basically detect by the Ishara chart. Okay, so this is one goes with C. Okay, then you have peripheral field of vision. Peripheral field of vision, how you see the peripheral field of vision? Peripheral field of vision you see with the help of perimetry. So 2 goes with D. Fair enough. Then Goldman applanation tonometry. What you do with the tonometer? you basically measure the intraocular pressure. So Goldman applanation tonometry, you basically do a IOP measurement, and hypopyon is seen in the patients with fungal corneal ulcer. Okay, so 1 goes with A, 2 goes with D, 3 goes with B, and 4 goes with A. Okay, so our answer would be B here. Okay, Saurav? Chal. So let's see few images here. So this is, you can see pus in the anterior chamber that is basically there in the patients of fungal corneal ulcer as well as bacterial corneal ulcer. You can also see it in the uveitis. So this is the hypopyon. This is the Ishihara chart. Ishihara chart where you see the Ishihara chart basically use in the patients where you want to detect the red-green color blindness. Then this is the perimetry. The type of perimetry is Humphrey visual fields. Here you can see the blind spot. And this is the Goldman applanation tonometry. Okay, Goldman applanation tonometry is the gold standard for measuring the intraocular pressure. Okay, let's move to our next question. So next question is most common ocular manifestation of COVID-19. So this was there were a lot of questions regarding COVID-19 in last few years. So that's why it is very important that remember the most important ocular manifestation is the follicular conjunctivitis. So few important points in short I would be telling about the COVID and its ocular manifestations. That the most common manifestation is conjunctivitis. If they have asked about the type of conjunctivitis, it is follicular conjunctivitis. Usually it is seen in the early infection, and last the Omicron variant, they have basically shown that sometimes the patient, the initial presentation is also your follicular conjunctivitis, but the best thing is that it is usually self-resolving. Okay, remember, if the patient, there is a mortality because of COVID-19, it is contraindication for the corneal transplant. Okay, and in the posterior segment, because in these patients there is a hyperviscosity, so the posterior segment manifestation, there can be a vascular occlusion, both central retinal artery occlusion as well as the venous occlusion. And these patients, because they are on steroids, so they are more prone to having a endogenous endophthalmitis. Okay, when we talk about the orbital manifestations, there are important orbital manifestation is the orbital cellulitis and sinusitis, and very important is because of the use of steroids there can be mucormycosis. Okay, that was a previous year question as well. And because of the drugs that we give, that can also cause the ocular manifestations. So corticosteroids that you give, that can cause cataract, glaucoma, central serous retinopathy. And the patients who are having intravenous IV IG that you are giving, that can also cause a central retinal venous occlusion. Okay, so with this we come to the last question of this session. So this was the picture they have given, and in this picture they have asked about what is the diagnosis. So your options are ankyloblepharon, pterygium, symblepharon, and stye. So as you can see in this picture, that there is a addition between the upper and lower lid. Okay, fibrotic addition between the upper and lower lid. Okay, so this is basically the ankyloblepharon. Okay, this is the ankyloblepharon. Ankyloblepharon can be a congenital ankyloblepharon. Very good, Dr. Stardust. And it can be a something which is a acquired as well. Okay, so it can be both congenital as well as acquired. This is the ankyloblepharon. And a similar condition can be a symblepharon as well, as you can see here, which can be seen in the chemical injuries where there is an addition between the conjunctiva. Okay, you can see there is a palpebral and bulbar conjunctiva, there is a fibrous addition there. It can basically extend up to the eyelid margin. So this is basically the symblepharon. Okay, so these are the two different types of blepharons that have been asked previously in your exam. Okay, so I think it is more than 1 hour 30 minutes now, and with this we basically end our session. So thank you very much for being here. So ophthalmology is something which is more image based, more clinical based, and you have to do a regular revision of the various questions. Previous year questions are important because these questions have been asked again and again, and these topics basically being asked uh, continuously, and these they have basically changed the pattern from more one liners to clinical based questions. So that is why in the AIMS exam, it is the INI-CET exam, it is very important you should have a thorough knowledge, as well as you should know what is the practical aspects of the various diagnostic tests as well. So if you have any doubts, you can ask us, and you can basically revise ophthalmology from our Manipal Medace app. You can get the best of the video lectures, the notes, and if you have any doubts, you can personally contact us. Thank you very much for attending this session. Take care.